Hello, and welcome to the Clinics Review Articles podcast. I'm Carrie Holland, Managing Editor for the Infectious Disease Clinics of North America here at Elsevier. Infectious Disease Clinics is a quarterly publication consisting of review articles focused on a central topic important to infectious disease physicians. In today's podcast, we will be discussing a recent issue on complex infectious disease issues in the intensive care unit. I want to welcome you and thank you for listening.
Hello, this is Helen Boucher from Tufts Medical Center. I am the consulting editor of ID Clinics of North America, and I'm delighted to welcome Drs. Naomi O'Grady and Samir Qadri, both from the National Institutes of Health in Bethesda, Maryland, who were associate editors of a recent edition of ID Clinics focused on complex infections in the intensive care unit. So, Drs. Qadri and O'Grady, maybe we can start with one of the biggest controversies in sepsis today, and that has to do with defining the disease. Dr. O'Grady, do you want to start with where you think we stand now in terms of appropriate definitions and some of the pros and cons of the new definitions?
Yeah, sure. I'll start by addressing the question of where do we stand right now. I think we stand a little bit closer to a more accurate definition, but within the confines of the definitions, we've sort of left ourselves in a bit of a quandary because we've changed the definition. It's caused a lot of controversy in the field, and there are pros and cons to the change in the definition. I'll let Dr. Qadri take it from here. He's studied the issue quite intensively and has a few opinions about where we stand.
I think while many of us have studied and maybe obsessed about sepsis for several decades, I think the one consensus there is that there is no true consensus on what sepsis really is. It's really hard to study something where, at the very crux, there is no gold standard. We're stuck with using the combination of expert opinion, clinical experience, and whatever data is out there to integrate and come up with what we think would be sort of the best way to name somebody as having sepsis or not. And about more than 2 decades ago, the first sort of standardized definition that was provided by the Society of Critical Care Medicine and the American Association of Chest Physicians, where they introduced the term SIRS, or Systemic Inflammatory Response Syndrome, which essentially is physiological and lab abnormalities that, if occur, where you had at least 2 or more sepsis SIRS criteria positive, and that was namely abnormalities in temperature, heart rate, respiratory rate, and a white blood cell count, along with clinical suspicion of infection, you were termed as having sepsis. If, along with that, there was evidence of organ dysfunction, and mind you, at that time, a precise definition for organ dysfunction was not provided, you were then labeled as severe sepsis. And then if you also had hypotension that was refractory to fluid resuscitation, you were termed as septic shock. Now, this construct sort of stayed in place for about 2 decades. Although there was significant criticism and controversy around it, we did have 20 years of work surrounding these 2 definitions. And so there's something to be said about that. Now, the need for a more a refined definition was essentially because of primarily around the criticism around SIRS. And the reason is because most started to feel that we were overcounting sepsis using the SIRS criteria, because the basic difference that the new definitions provide compared to the old one is that they think of sepsis as a dysregulated host response to infection that manifests in the form of organ dysfunction. Whereas the previous idea of sepsis, which was SIRS plus infection, essentially could be infection plus normal physiologic response. And I think that is in principle the difference between the old and the new definition. And then, in terms of the negatives around SIRS, more recently we have evidence to suggest that about 50% of patients who are admitted to wards with suspected infection and meet positive SIRS criteria, even though they may not necessarily be septic. And also a recent study in the New England Journal told us that 1 in 8 patients who have sepsis and organ dysfunction do not necessarily meet the SIRS criteria. Many of these patients actually die. But there is another school of thought, which is that if you're focusing on dysregulated host response and the presence of organ dysfunction, maybe we might miss patients who are potentially on the floor, with early signs of sepsis that may be caught with the SIRS criteria. So I think when we move on, I'll talk a little bit about the new definitions now. The new definitions of sepsis, which is sort of part of the third iteration by the SCCM-ACCP, essentially now define sepsis as infection and organ dysfunction. And organ dysfunction here is classified as a SOFA score change or increase of 2 or greater. Now, the SOFA score, or the Sequential Organ Failure Assessment Score, was initially provided, I think, in 1996 by Jean-Louis Vincent's group. And it has essentially played an important role in understanding cumulative acute organ dysfunction in ICU patients over time that is sepsis related. And so with some work that was done by the sort of core investigator group that came up with these definitions, they found that this definition was reasonably predictive of a poor outcome. And what we now have is a definition of sepsis that is based on our prediction of poor outcomes. The new definitions don't really help us in terms of, do they really impact outcomes in terms of earlier detection and in terms of, better survival. All they're saying is that if you use this new definition, you're going to capture patients with a high predictive risk of mortality. And so there's good and bad to that, because the good is that I think we've improved our specificity compared to the older definitions, but we may miss people. And, a caveat to that is that as part of these definitions, they also provided something called as the QSOFA, or the quick SOFA, which is not necessarily part of the definition, but is sort of an adjunct to maybe capture patients early on the wards, and is a sort of a quick and dirty way of doing this, because it involves essentially a clinical exam where if you have a elevated respiratory rate and you have hypotension, and I believe the third one is an elevated heart rate, you meet sort of quick SOFA criteria, which is sort of a sign that you may be having beginnings of organ dysfunction. We're still in a process of understanding how well the quick SOFA performs in terms of earlier detection on the wards, and I think it's a work in progress. But if I were to summarize all of this, I would say that I think this is an improvement. I think that we should not completely dismiss SIRS, because there is this potential advantage of catching people early, but at the same time, giving more quantitative meaning to organ dysfunction is an improvement. And I think for the future, if there were to be a new iteration, I would love to see a definition where organ dysfunction could be more attributed to the infection, which in the current system it doesn't.
Well, thank you very much. I really appreciate the comments about the clinical identification of these patients, and it's encouraging to know that physical exams are still important. I wondered if we could just push a little further. Two things that seem to come up a lot have to do with lactate, who gets one and how often, and then the regulatory piece with the new CMS mandate, if either of you wanted to comment on either or both of those topics.
Sure. I can talk a little bit about the regulatory piece and the CMS mandate. You know, there's been work recently in 3 large randomized trials that indicate really no benefit to using the bundle that has been proposed. In other words, the early goal-directed therapy study, on which most of the recommendations were based, was a single center study, and a rather small study at that, which essentially changed clinical practice before it had actually been validated in a multi-center randomized trial. We now have 3 multi-center randomized trials that have not been able to validate this strategy. And so I think that there is work being done at CMS to relook at the bundle and the mandate such that things like the lactate might be removed from the bundle potentially. I don't want to speak for CMS, but certainly I think there are many people who are taking a hard look at this to see whether or not we can redeploy our resources in a more useful fashion rather than chasing a lactate that might not make a difference.
I agree. And, I just want to sort of add that what CMS is wanting to do is use data from CMS hospitals, which I think are close to around 4,000 hospitals in the U.S., from 2017 to measure compliance with the SEP1 measure across hospitals. And this data is going to be publicly available on Hospital Compare. There are important implications to this because I think that in principle, the intent is good and is desirable, because I think hospitals should be, held accountable for performance, and citizens of our society who use these hospitals should have, a choice and a say in where they want to go based on how good these hospitals are. But the caveat is, how good are these measures? Some work that, some important work that was done by some of our colleagues here at NIH that was recently published in the Annals, speaks very strongly to the fact that some of the components of the SEP1 measure, especially around tissue perfusion and volume status assessments, are based on, little or no high or moderate quality evidence. So how good really are these measures? And, I think in response to this, there have been some updates and to the measure, and essentially the volume status and tissue perfusion components have actually been taken out of the measure. And many people are looking at this with a keen eye and are highly critical. And, it speaks to the sentiment and the value of deep thinkers and people that are concerned about the health of our society, and are working very hard to make sure that regulatory mandates don't necessarily run the show, especially when they're not supported by good quality evidence. And then, just sort of to touch a little bit in terms of the lactate piece, I think if you ask me, compared to the era where lactate was not used, we probably are picking up more people with sepsis today than we did earlier. So I think there's some good to this. And when you see a high lactate in the ER, it does raise eyebrows. And I think that there was some good in terms of bringing the attention to providers that if there is a high lactate, I think you should be alerted that there may be hypoperfusion, and some of this may be contributed to by sepsis. So there's good to this, but I don't think to date there has been a study that has shown that subsequent lactate assessments, definitively improve outcomes. A recent study, which I think was presented at the Society of Critical Care meeting this year by some of our colleagues from Harvard, looked at 5 hospitals in Massachusetts where they looked at whether the SEP1 measure was fulfilled or not in patients with who arrived to these hospitals with suspected sepsis, and they compared the outcomes in the people in whom the measure was occurred and did not occur. And actually what they found interestingly was that there was no significant difference in the outcomes. What was really interesting to me is when they dig deeper, they found that of these patients, the reasons for the SEP1 measure not going through with these patients was not related to delayed antibiotics. Antibiotics were actually being administered quite promptly and effectively. This was more related to non-measurements of lactates, as well as not providing the stipulated 30 cc's per kg of volume to all patients. And I think I want to make the argument that it makes me think that people are not following this measure by the book, and they're in fact putting some thought into how much volume each patient should get, and whether a lactate is mandated or not, and or required or not, rather. It gives me the sense that there's some thought into not complying with this measure, which may actually be more important to the patient.
There's always this problem. There's always this lag time of when guidelines are introduced and recommendations are made. New data comes to the surface. New data is generated that may be in contradistinction to what the guidelines recommend, and it takes time for guidelines to be updated and recommendations to be updated. So I think that's one of the problems that we're facing here, which was that the original backbone of the guideline was this single-center trial, which defined basically a protocol for early goal-directed therapy. But key elements of that protocol were actually not validated in these 3 randomized trials. And despite the emergence of this new data, the guidelines have not been updated, and CMS has picked that up. And we are working hard and working with CMS to see if we can't get some of that corrected.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I want to turn our attention now to a couple of other maybe quick topics, but perhaps just as controversial. So the first one has to do with invasive fungal infections in the ICU. And I wonder if you all would comment a little bit about Candida and Aspergillus in particular, but also on the whole empirical therapy for fungal infections, certainly something for which a very large number of healthcare dollars are spent every year in the United States.
I'll talk a little bit about invasive candidiasis first. We know that that's a significant problem in the ICU, affecting patients with a variety of risk factors. So certainly patients who are immunosuppressed, but maybe immunosuppressed in a less traditional way, in that they may have diabetes, they may have pancreatitis, they may have liver disease, they may have central venous catheters, they may have illnesses that lead to having invasive candidiasis, particularly patients who require abdominal surgery. They are at high risk for invasive candidiasis. And so, we look carefully at patients knowing that those risks predispose them to potential for invasive candidiasis. We like to jump on that diagnosis as quickly as we can because we do know that the longer the patient goes untreated, the more likely their mortality risk is increased. There's been a lot of effort that's been made to diagnose these types of infection early. Still, standard cultures are really the gold standard, but cultures can take anywhere from 2 to 5 days to become positive, and truthfully, only about 50% of all patients who have invasive candidiasis will have positive blood cultures. Now, that can be as high as 80% in patients who are bacteremic, but in patients who are not bacteremic, it could be as low as 20% that would be culture positive. So a lot of effort has been made to use rapid diagnostic tests for invasive candidiasis.
I think in terms of rapid diagnostics, it's really a work in progress, but we are starting to see emerging evidence that there may be some value in further exploring some of the modalities for rapid diagnostics, and they do hold promise in the future, I think. For instance, there is an assay that was FDA approved very recently for the diagnosis of candidemia, and this, I believe, it's an assay where the DNA is magnified or amplified, and then magnetic resonance is used essentially to identify this in layman's terms, if you will. I think it looks at 5 major species, or looks for 5 major species: Candida albicans, glabrata, tropicalis, krusei, and paracellosis. What was found was that when they compared everybody with a positive blood culture with one of these organisms and also simultaneously ran the assay, they found that about 89% of these cases of true bloodstream positive Candidan species were captured by this assay. So it's not perfect, but it comes close. But what's interesting is that there were many cases in which these DNA were amplified and identified in cases where the blood cultures were not positive. And, we don't have as much evidence in terms of its value in deep-seated candidiasis, invasive candidiasis that may be blood culture negative. And so I think that's where there may be more promise. I'll be intrigued to see more work done comparing, for instance, biopsy specimens of, proven deep-seated invasive Candida, and how this assay may perform in that instance, where it might capture, I think, cases in the blood which are not in fact positive through conventional culture. So I think it's work in progress, but I think there might be some promise there.
I think we're a little bit further along in the case of Aspergillus, in that I think there has been a broader recognition that patients who are not immunocompromised in the traditional sense are at risk for aspergillosis in the ICU, particularly patients who have underlying pulmonary disease such as COPD, patients who are on the ventilator for a significant number of days, and then patients who have other risk factors like diabetes, cirrhosis, and other illnesses that might predispose them to being somewhat immunosuppressed. The diagnostic tests that we have relied on in the past have been, particularly for pulmonary aspergillosis, is the BAL. But BAL alone is really not good enough because patients can be colonized with aspergillus, and the lungs aren't traditionally thought of as a sterile site. So some of the more rapid diagnostic tests that we rely on are the galactomannan test, and certainly there's more information coming out that the use of the galactomannan test in the BAL provides quite a bit more specificity than the lactomannan test in the blood. I don't know if you want to talk more about that, but I think that's a very useful tool that we have to add to our armamentarium of diagnostics.
And I think, Helen, you brought up an important question also about, empiric antifungal therapy. Again, I think a very important topic that is on the interface of infectious disease and critical care, which really our issue in the clinics is trying to kind of bring out. There was a recent trial that was published in JAMA called as the Infectious trial, that was essentially non-neutropenic critically ill patients with ICU acquired sepsis, and what they found was that if you were colonized with Candida, and you received this empiric therapy, it did not really increase fungal infection-free survival at 28 days. And I think this is important information to us, but at the same time, if you ask clinicians, who take care of these patients in the ICU, many would argue that the downside to giving echinocandin therapy is not too much. The downside of missing a case of, invasive candidiasis, candidemia can be pretty profound, especially given that patients who get these infections are either extremely acutely ill, instrumented in the ICU, or have, underlying immune compromising conditions that anyways increase their risk of dying. So again, I think a work in progress, but I think the bottom line is if the patient has the appropriate risk factors and has a high risk of dying, such as septic shock, I don't think that there's a huge downside to this. Again, of course, there is this counter argument, I think, that we hear more from our infectious disease colleagues that, there has to be a middle path here because we're starting to see more non-albicans species and, they essentially are more resistant to our traditional antifungal therapy and this change has occurred sort of in the last decade or so where we are seeing glabrata that was not only resistant to azoles, but also resistant to echinocandins. And we're starting to see the emergence of some, not very common, but very clinically important species such as Candida auris that the CDC is all over, where, you can see a resistance to all three categories of antifungals.
Great points, and sort of highlighting the need to always push for identification and often susceptibility testing of Candida when we do find it. So in the last few minutes, I was hoping, and you actually kind of transitioned us nicely into this discussion of the evolving relationship between infectious disease and critical care physicians, which obviously is a very close partnership in many of our institutions, but now we're paving the way for the training of dual-boarded infectious disease and critical care physicians. And I wonder if you all could comment on your thoughts about that and how these young physicians are finding careers and what your hope for the future might be.
Well, Samira and I, as you know, were involved in a study in which we surveyed physicians who were trained and boarded in both critical care and infectious diseases. And although there aren't a lot of them, we have seen a trend in the last 10 years that the number of people choosing this type of pathway has been increasing. And there are probably a variety of reasons for that. I think that infectious disease and critical care are really two specialties that in internal medicine that are not organ specific. And people, I think, who gravitate towards one or the other specialty, they tend to like both the cerebral specialty and the procedure side of the critical care specialty. So it does lend itself nicely to a unique perspective in the ICU and in infectious diseases. So the the demand for the training, I think, is driven by a couple of things. Number one, we should make no secret of the fact that salary for infectious disease physicians has been lacking, and I think that is one of the drivers that sort of moves people toward critical care, and the idea that they could combine both specialties is quite attractive. Salaries for infectious disease physicians are in fact lower than those of general internal medicine physicians, and it's very difficult to convince a young trainee to take on 2 more years of training for infectious diseases when they can earn more money by going out and practicing critical care. So I think that the training is certainly an attractive part of the combined specialty.
I think one of the reasons why we felt the need to investigate whether this dual specialty really, holds merit and is important, because we had published a viewpoint article in CID on this concept and on increasing number of physicians getting dually boarded in infectious disease critical care, and soon after that we got sort of a influx of emails from multiple people, ranging from medical students, residents, fellows, and established physicians in one field, asking us more about this field, and most importantly, asking what is the practical route for them to take. What are the pathways that exist? I think that this led us to do this survey, and as Naomi mentioned, the findings were very favorable in terms of what we call in our title synergy, salary, and satisfaction. And really, I think that's the mantra here. And we encourage anybody interested in this dual field that today in 2018 there are more opportunities in terms of diverse careers that could really benefit from this combination than maybe a couple years ago. There's also a push from the IDSA. They're really trying hard to assess whether matched results were better at centers where they are providing these dual training opportunities compared to a conventional ID. So I think that's sort of underway. And the other thing that they're trying to develop is an official curriculum that centers interested in dual training can use as an outline or a guideline. I think that the final step then would be to present this to the ACGME, to see if we can formalize dual training, given the great degree of interest, but currently less practical ways of attaining this dual training.
And what essentially drives some of this is the unique synergy the combined specialties provide. I mean, there are a couple of examples where we've had some significant impact on the practice of medicine, and I'll just take central venous catheter infections, for example. Over the last 20 years, most of the prevention strategies related to central venous catheters were focused in the ICU, simply because most patients receive their catheter placements in the ICU setting. So as things have evolved, we know that education and training on how to insert lines makes a difference. We know that some of the novel technologies and new strategies that have evolved, such as antibiotic impregnated catheters, have made a difference. But mostly because of the synergy between the infectious disease field and the critical care world, there has been a unique combination of efforts that have led to a dramatic decrease in central venous catheter infection rates over the last 2 decades. So there are the combined specialty does fulfill a unique niche. However, it's not so unique as to be thought of in a super specialized way. There is definitely a need for a person with combined training in almost every hospital in the country.
I think just to add to that, there are some people that have brought up, potential reasons why this may not be a good combination, which is worth discussing as well. There was some concern that procedural aspects such as bronchoscopies, may not be as frequent in the training of people with ID critical care other than, for instance, pulmonary critical care. But I think that, there is a minimum requirement as part of critical care training at the core where I think can't graduate if you don't get sufficient training in bronchoscopy in the ICU. So I think, that's one example where I think how we define training requirements is going to be really important moving forward, not only to ensure that, most parties are satisfied with the training requirements, but also that, patient safety is continued to be sort of our paramount priority. I think another couple examples where I think this synergistic combination holds promise is in terms of leadership in the fight against antimicrobial resistance. Antimicrobial resistance infections, as Helen, you know very well, have an overwhelming presence in the ICU. And it looks like this problem is not going away anytime soon. If we had somebody dually trained in every major ICU in the country, I can see how they can be a liaison between the ID group, the stewardships groups, as well as the intensivists and the other critical care providers, where they can ensure a balance between appropriate and judicious use of antimicrobials in, cohorting patients, infection control.
There is this tension that exists between the intensivist and the infection control practitioner from time to time.
Correct.
As it relates to antibiotic stewardship, as it relates to isolating patients and putting them in contact precautions, as it relates to having a very complicated patient in the intensive care unit with a multi-drug resistant bug and scheduling testing, for example, imaging testing, CT scans, MRIs, at the end of the day, so that a terminal clean for all of the equipment that was used to transport that patient is important. So somebody who's duly trained really does add some value, I think, to at least every tertiary care center in the country.
I think maybe this is a great place for us to wrap it up. We might have a potential for another challenge paper to have one dual trained leader. And it sounds like, one of the things that you all didn't specifically articulate, but the leadership component here is so important, and having a leader in every institution or tertiary care institution really makes a great deal of sense at multiple levels. And as you pointed out, Dr. O'Grady, with some of the regulatory things that CMS cares about, like central line infections, just one example of many, could be a real opportunity for us. So I want to really thank you both and all your co-authors for a truly outstanding edition of ID Clinics, and hope that many will benefit going forward. And I know that we are grateful to all your many contributions in the field.
Well, thank you for the opportunity.
Thank you.
Thank you for joining us for this edition of the Clinics Review Articles podcast. For an exclusive discount on the issue we discussed today, focusing on complex infectious disease issues in the intensive care unit, visit us.elsevierhealth.com/expert. Infectious Disease Clinics is available for individual print subscription with accompanying online access, individual-only online access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter @Clinics Reviews and subscribe to the Clinics Review Articles podcast on iTunes and the Google Play Store.